Welcome to this week's episode of Pocket Pearls. I'm here with two of my co-residents, Dr. Stephanie Parks, formerly Dr. Stephanie Gargano, and Dr. Adrian Worth. And today we're going to discuss some of the controversy that surrounds using NSAIDs in obstetric patients that have hypertensive complications affecting pregnancy. So we're going to review some of the physiology behind this issue and then discuss some of the evidence to help inform medical decision making. So Dr. Worth has some questions for us today.
So, Dr. Parks, why do some people oppose the use of non-steroidal anti-inflammatory drugs, NSAIDs, for use in hypertensive OB patients?
That's a great question. So one of the reasons that people oppose the use is that there is some evidence that shows that it can increase blood pressure by about 5 millimeters of mercury. However, these studies were done in non-pregnant people with chronic hypertension, and there's no studies that have been done in women with pregnancy and hypertension.
Do we know why NSAIDs affect blood pressure?
We do. Certainly someone like a nephrologist would be able to give you a much better answer, but I can try to give you a gross oversimplification. So what you have to do is think back to medical school and think back to the kidney. And the functional unit of the kidney is the nephron, and the point of filtration within the nephron is the glomerulus. The afferent arteriole brings blood into the glomerulus, and it's carried away by the efferent arteriole. Prostaglandins at the level of the glomerulus function to dilate the afferent arteriole, so the vessel bringing blood into the unit of filtration. NSAIDs will inhibit prostaglandin production, so they'll inhibit the ability of the afferent arteriole to dilate, leading to constriction of this arteriole, which will decrease renal blood flow. Decreasing renal blood flow at the level of the nephron will increase sodium reabsorption and lead to vascular resistance. So this is one of the many mechanisms physiologically by which NSAIDs can slightly bump up blood pressure, and usually it's with prolonged chronic use.
So why is it important to be able to use NSAIDs?
They're compatible with breastfeeding, they're effective, and they reduce narcotic use.
So Dr. Klebanoff, what does ACOG say about NSAID use?
That's a very important topic to discuss. And in 2013, ACOG released their, what is probably now very well known, their hypertensive task force, their recommendations regarding the management of hypertension in pregnancy. And within this document, there's very little mention of the use of NSAIDs in pregnant patients. But what they do comment is that really we should try to avoid using NSAIDs in women that are affected with hypertensive disorders in pregnancy who have persistent hypertension for one day after delivery. They also go on to say that basically if you have a woman with chronic hypertension in pregnancy, you should really try to avoid these medications in those patients, acknowledging again, like Dr. Parks talked about, that this data is extrapolated from non-pregnant chronic hypertensives.
Is there other available evidence?
There is actually. In October of this year, there was a study published in the Green Journal that examined this exact topic. What they did was they looked at women with preeclampsia with severe features who remained hypertensive 24 hours after delivery. The postpartum women were then grouped by whether or not they had received NSAIDs.
So what were they looking for in this study?
They were looking for those women that had persistent elevated blood pressures in the postpartum period. And the way they defined hypertension in the postpartum period was with a systolic blood pressure greater than or equal to 150 and a diastolic greater than or equal to 100.
So what did they find?
What they found was that about 75% of the patients had received NSAIDs and 25% had not. Women who had a C-section for delivery were more likely to have received NSAIDs. But overall, there is no significant difference in persistent postpartum hypertension in the women who received NSAIDs compared to the women who did not.
Should we disregard the task force and give NSAIDs to all postpartum women, including those with hypertension?
That's a really important question, and it seems like based on this one retrospective study, probably not. Importantly, the authors do point out that one of their limitations was that even though they were giving postpartum hypertensive women NSAIDs, it didn't actually decrease their overall narcotic use. They do admit that the study wasn't adequately powered to assess that, but it's important that if the NSAIDs aren't doing what in theory they should be doing, should we be giving these women any additional risk? They comment at the end of their study that this is a very important topic, and really what it needs is an adequately powered randomized trial to assess this very question. To put everything we talked about into context today, this is a very important question, There is a physiologic explanation as to why NSAIDs will elevate a patient's blood pressure, though we have to acknowledge it hasn't been studied in a pregnant population. The studies that do look at non-pregnant and chronic hypertensive patients, usually the course of treatment that they're receiving these NSAIDs is usually for at least 7 to 10 days before they'll have elevations in blood pressure, and in general, we're using NSAIDs for arguably a shorter course, though it's not uncommon for women to take these medications at home. The ACOG task force does say that if you cannot use NSAIDs, then you shouldn't. There is more recent evidence, like the October article that was published in the Green Journal, showing that there was no difference in blood pressures between those patients that were hypertensive that got NSAIDs and those that didn't. But again, it was a retrospective cohort study. So hopefully this is something that will be studied in the future. Join us next week for another episode of Pocket Pearls.
We're done in people who have chronic hypertension, not pregnant. No.
Nope, it's all lost.
It's lost.
3, 2.
However, these studies were done in women who, they weren't done in women.
Do we know why NSAIDs affect blood pressure?
Do we?
Pain control. They're compatible with breastfeeding. Just, you gotta be, really, this is just, can you cut that out?
Should we disregard the
I'm sorry, that one was my fault. I wasn't prepared for the mental prep work that just happened before asking that question.
She did get very mentally prepared for it.
Okay.
You ready?
Yeah.
Okay.
Should we disregard the task force?
Why can't you say task force?
Yeah, I need a minute.
You're not still filming, are you? All right. This one you got. Task force.
Task force. Fuck you.